Good afternoon, everybody. We're just at 2:30 now. I might make a start. So welcome, everybody. My name is Jacinta Greene. I'm the convener of the Nutrition and Health Study Group at the DSAI, and delighted to be here this afternoon and privileged to be facilitating this event with all of our guest speakers that we have lined up. The theme of this year's conference is about climate and climate of and climate for development. So we're hopeful that we will look at that a little bit more with the lens on kind of nutrition and health for this session in particular. So we have 4 speakers, and we have 4 different sessions, and we're going to go through each one of them in time, and then we will have questions and answers and discussion, more of a general discussion towards the end. So I just wanted to let you know this webinar will be recorded, and the webinar will be recorded, and we hope to make it as interactive as possible. So if people would like to record, type in questions as we go along, we hopefully will get to them in the questions and the discussion part towards the end. And also, if you want to share comments, feel free to do that also in the chat box. So let me see. So we've asked each of the speakers to maybe present for 10-15 minutes, and then hopefully at the end we can have all of the discussion with everybody towards the end. So to start with, I'm going to not delay any further and introduce our very first speaker, which is Anne Matthews. So Anne is a professor at the School of Nursing, Psychotherapy and Community Health at Dublin City University, Ireland. She's a registered general nurse and a registered midwife, and her PhD research was on power and empowerment in midwifery in Ireland. She leads on the BSc in Health and Society at DCU, and she previously worked in a variety of clinical research and policy positions in Ireland, in the UK, and also in Malawi. So Anne is going to lead us out in one of probably the most significant environmentally friendly ways of feeding, which is breastfeeding. And she's going to talk to us around what enables and hinders the implementation of the baby-friendly hospital and the community initiatives to support breastfeeding globally. And she's going to talk to us about their findings from their scoping review. So I'm delighted to have you and to start this conversation. Thanks, Anne. Over to you.
Thanks, Jacinta, and thanks to everybody who's joined and to the other speakers as well. And I'm just reminded from what Jacinta is saying about the overall theme of the conference, and also our topic of breastfeeding, that they are, so closely related. But unfortunately, we're not going to contribute too much to that, but it is in the background. And I think increasingly people are realizing, that breastfeeding, helps meet all the SDGs, and also the International Confederation of Midwives, their president recently was, involved in being, very much tweeting that midwives have always been contributing towards decarbonization. So that is definitely in the background, but I just want to thank Jacinta for always being so accommodating for our various presentations, for bringing us together, and even if things don't fit exactly, we're always welcomed, so thank you for that. This is our school here in Dublin City University. We're the building on the left, and my name is there underlined. I see Ellen Petersea is here as well. Ellen's involved in organising the whole conference, so well done on that. And then our collaborators in the Royal College of Surgeons and the Kamuzu University of Health Sciences. the Kamuzu College of Nursing and the College of Medicine in Malawi have recently formed the Kamuzu University of Health Sciences, and our former graduate of DCU, Zoe, as well. So as Jacinta said, we're going to focus on the findings of a scoping review today. But just to just to say that this is part of this bigger project, evidence, enhancing, trying to find and communicate evidence about infant feeding policy implementation in Malawi, with wider transferability as much as we can. It's a 3-year project funded by the Irish Research Council. It's the Coalesce grants, so it's the strand that's also funded by the Department of Foreign Affairs with the Irish Aid, and we're into the last 6 months now of the 3 years. That's myself and Ellen. Aisling has been there from the beginning, and Ellen Peterson joined us after a couple of months as our postdoctoral researcher. This scoping review, which is this part, the roundy part in the middle, is being led by Aisling Walsh, our colleague in the Royal College of Surgeons, with whom we've collaborated on other projects, and hope to do so again in the future. And our other colleagues from Malawi, Maria and Chimwemwe, have joined in this part of the project and some other parts, and as I mentioned, Zoe. Just over on the right, I think maybe last year, Ellen presented on our realist synthesis work. I suppose on our first field visit to Malawi in 2019, we were just broadly interested in infant feeding policy implementation, and particularly, I suppose, we were wondering about all these kind of global initiatives that were, definitely top down in terms of the global kind of implementation push, but how were they implemented at a country level, at a local level, or were other initiatives happening, more on a bottom up level? But the two things that really were highlighted to us on that first visit were the Baby Friendly Hospital Initiative, which had been revitalized in Malawi a couple of years before that, and also care groups. So this arrangement of peer-to-peer health education support groups in communities, mostly mother to mother. It's quite a structured approach. Care group volunteers and people who organize those and people who organize those. So it's quite a hierarchical structure in a way, but the idea is that every family with children up to 2 or some places up to 5 would have visits from these from a care group volunteer who would support them with water, sanitation advice, and in particular for us, breastfeeding, exclusive breastfeeding advice, and also weaning advice. So probably this time last year, yes, we were presenting our realist synthesis, which is desk-based research. And since then, our colleagues in Malawi have been able to carry out some field research in Dedza, one district in Malawi, and that enabled us to look at care groups in action. Places where there were care groups supported by a number of international donors, and other places where there were no care groups, and just to see how people perceived them, and also how they were supported to breastfeed generally. So hopefully maybe this time next year we'll be back with these findings of our field research, 61 interviews with women who have children, infants, or up to 2 years, as well as village leaders, health surveillance assistants, all those involved in the care groups, and also then the district level nutrition people and the district level health people. I suppose something we found really, which is why this group is so attractive, the nutrition and health group, is that, obviously in many countries and in Malawi, health and nutrition are considered together, and yet maybe the infrastructure for nutrition is sometimes behind the infrastructure for health. So there are lots of plans maybe to strengthen that, the nutrition kind of health workforce down to district and then below the district level. So just going back to the Baby Friendly, the Baby Friendly Hospital Initiative and the Baby Friendly Community Initiative, that's what we'll focus on today. And most people have probably heard of the Baby Friendly Hospital Initiative. It was established by the World Health Organization and UNICEF, revised, and as I say, revitalized more recently. These are the 10 steps that you'll probably see around health facilities should be in every country, but hopefully these are somewhat familiar as we said, they have been revised, and particularly looking at, you know, the kind of number 1 and number 10. I suppose the reason why the 10th step is important to us because the Baby Friendly Community Initiative has grown out of that. So this is really, these are all based on hospital, and this, and the motivation behind step 10 is, you know, to support women when they leave the health facility or hospital. You know, what is the role of the health system in supporting women once they leave those kind of formal systems? Just to go back to what I said at the beginning about breastfeeding and sustainable development and the SDGs generally, the World Alliance for Breastfeeding has, you know, this infographic whereby if you click each SDG, it'll tell you how breastfeeding would contribute towards that goal. Obviously, that's, you know, some of them are so obvious about poverty, hunger, health, and, you know, then right up through about consumption and, you know, water, climate, all of the elements, as well as gender and education and all of those. So, you know, lots of reasons to support breastfeeding. And what struck us at the very beginning of this project several years ago was that this was so obvious, something that would have an impact. You know, why have the rates not necessarily shifted? And, you know, obviously Ireland is, you know, in the very low end of that scale of breastfeeding rates. So our scoping review, you know, we were interested in Baby Friendly Hospital Initiative and Baby Friendly Community Initiative, and we set about a scoping review led by Aisling, as I said. We published our protocol in the HRB open repository, which I really recommend if any of your team has funding from the HRB, the Health Research Board of Ireland. So any of your team as a co-applicant on another project, it doesn't have to be on the project, then you can publish here. It's an open publishing resource. Your initial paper goes up, some peer reviewers are invited, those peer reviews are open, you respond, and when you have 2 peer reviews back, then it gets kind of released. So that was really helpful for us. We got some great feedback from international reviewers and national reviewers. So the goal of a scoping review really is to map and, you know, chart out, see what's the extent of the evidence. We wanted to give an overview of these approaches to implementation, look at the barriers, enablers, identify knowledge gaps. So that fits with the idea of a scoping review. And our methods, those of you who do this kind of work will be familiar with Joanna Briggs Institute, where they, you know, the groups working here, starting off from nursing and midwifery, found that, you know, while there's a lot of guidance for systematic reviews of RCTs, there wasn't as much guidance for scoping reviews. So they are building on some of this other work, some very recent guidance, and these are the 6 stages. So it is, I suppose, different to a systematic review of effectiveness of an intervention where you're trying to come up with a numerical maybe score. Yes, this intervention is, you know, 3 times as successful as this other one. Here you're really charting out what's happening, summarizing, reporting results, and it is very, you know, you're approaching it with a very kind of open plan because, you know, you're trying to find all the evidence that exists. Just to say, we did register our title for our review with Open Science Framework. Again, that just means, you know, it potentially cuts down on duplication. If somebody else was doing it at the same time, they would be able to find ours. And often it can be hard to know how to present the results of a scoping review. So we came across this really good article by Caroline Bradbury-Jones and colleagues. They were trying to as well improve the reporting of the results of a scoping review. So they had suggested this framework looking at the patterns of evidence, the advances, chronologically, the gaps, and then really trying to speak to different audiences in practice or for research. Just to say that we ended up, this is our, you know, the outputs. This is in Covidence, which is a package that you can use to screen and extract data. So we started off with 3,700 references, lots of duplicates, 2,800 excluded because they weren't about Baby Friendly Hospital Initiative. We found a lot that, you know, maybe had the same acronym, BFHI, but it was a totally different scale or a drug. And then we were looking down through full text. So these are the reasons why these were excluded. We were probably more inclusive than we ended up being, but we did have 244 studies in the end, and that's probably a lot. Well, it definitely is a lot. I think Ellen can confirm that as well. So, you know, because of our constraints, we set out our parameters in our registration of our title and our protocol that we would only access papers in English. Obviously, you know, those are all decisions to be made. So on the 244 included studies, these are some of the questions that we're interested in. So by steps, I mean the Baby Friendly Hospital Initiative steps, the 10 steps. So most of them covered all of the steps. So they were checking up how was Baby Friendly Hospital Initiative implemented as a whole. Some of those were pre-baby, getting ready for Baby Friendly Hospital. Sorry, that doesn't make sense there, Baby Friendly Hospital only. I think that's comparing it to maybe the community. That can probably combine in with that one. And these are the ones where it's step 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So these are the number of studies that were just about those ones. And I mean, step 10 is really about policies and systems, right down to step 10 about discharge and having, you know, coordinated packages in place. Some of them you'll see skin to skin contact is really vital. You know, lots of others, I won't go through all of those. Some studies about rooming in, which is the practice of babies staying with the newborn babies staying with their mothers, which now is kind of taken for granted, but that's definitely changed over time. So in terms of countries, there was one study from each of the top countries, right down to the USA had most studies. So there was a lot of efforts to implement Baby Friendly Hospital across each state, across several states, and then, you know, at sub-state level, even in a city or in a hospital. So most of the evidence was coming from the United States, and you can see some other developed and emerging economies there. And lots of countries, and then we see some of the countries that we'll focus on a little bit more today. Various designs, different kinds of studies carried out. I'll come back to that with the studies we're going to focus on. Most of the studies had mothers and babies as their participants as such. It's hard to distinguish between mothers and babies only, because that would be breastfeeding data, or maybe, you know, data on the progress or the health of babies. Lots of studies of health workers, and lots of studies where mothers and health workers were included. Low and middle income countries. So we asked, I suppose we had a question at the beginning about equity, you know, to what extent was equity kind of covered in some of these, and there wasn't that much discussion, I suppose. Some, you know, particularly talked about some of the populations that were studied, where there, you know, was it more difficult to reach maybe people due to various characteristics of the population, but it wasn't something that really featured in a lot of studies. So just to say, I suppose the 7 countries that I highlighted earlier were covered in 21 reports of studies. But just to say, you know, particularly Kenya, you know, where there was a implementation of the Baby Friendly Community Initiative, lots of studies were about the same intervention, really, the same implementation process. So that's the difference as well between a scoping review. You take each piece of evidence, each article as a separate item, whereas in a systematic review, you're looking for one set of data from a study, not an article. So, you know, mostly here surveys, some trials reported, and mostly Baby Friendly Hospital, and again, the newborn and the mothers. So this is as far as we've gotten really with our provisional findings related to these countries. And I appreciate there's a difficulty with the, you know, a region, calling sub-Saharan African countries a region, given the huge differences across countries and within countries. But this is the kind of thing we're beginning to do, look at a pattern of evidence, think about how the evidence has changed over time, some of the gaps in terms of, you know, monitoring of ongoing evidence. Have to say training and ongoing training and the attitudes of health workers coming up again and again. And really, rather than all these cross-sectional or qualitative studies, the need to really have more longitudinal studies. You know, we see some studies focusing on one or other of the steps. Really, that's where you see attitudes and cultural practices really coming to the fore. you know, people having, whether it's mothers themselves or their relatives or the health workers, having various views on that. And Baby Friendly Community Initiative, I suppose, for something that is seen to have been implemented very positively where it was and studied really rigorously, there are improvements, but you know, you would have expect almost more implementation given the apparent impact there. Very difficult to sustain all of these things over time. So just in conclusion, we were all learning how to do a scoping review together. Well, some people had previous experience. We found it useful to register the title and publish the protocol. We are a team across 2 or 3 institutions now. We were able to share the software, which sometimes is difficult. We're finding at the moment with another software, Covidence, if anybody wants to come back about how to use that, that would be great. We did pilot data extraction. Each member of the team did that, of the 7 of us. And now I suppose we ended up, because there were 244 studies included, very large volume of data. But we can see in there are some subsets of data, for example, baby-friendly neonatal or neo-baby-friendly settings. So we're going to look back on those, and that's all work in progress. So just to say for today, thank you. And myself and Ellen are here, and we can answer any questions at the end in the panel, and look forward to joining that after the other presenters. So thank you. Hope I didn't go too far over.
No, not at all. That was perfect. Thanks a million. And that's really interesting. And it just goes to show what a big task you had from those thousands of papers. And just even take the global approach. It's incredible and so interesting. But I've no doubt you were immersed in data and you know, from that. So no, thanks for talking us through the principles as much as your results, because there's definitely learning in that as well. So thanks very much. And a great presentation to start us off. But I am going to move on, and we'll save all the questions. And again, just a reminder to everybody, put any questions or comments that you might have in either the chat box or questions and answers, and hopefully we can come back to them. So thanks for that. So our second presentation, and we've got 2 speakers. We've actually 4 speakers from GOAL, but 2 of them are doing the next joint presentation. So I'm delighted to introduce Mesrak Nadew and Isabelle Bremaud, and they're going to talk to us about fragility and health resilience, building health resilience of communities and health systems to climatic shocks and stresses. So just to introduce the 2 ladies, Mesrak Nadew is the resilience lead for Monument Integrated Health Resilience. So she's worked in international health for almost 20 years on health systems, strengthening infectious disease control, family planning, reproductive health, maternal and child health for organizations including GOAL, USAID, Intra Health International, the Carter Center, and GOAL. And Mesrak is joined by Isabelle Bremaud, also working in GOAL, and she's the Global Resilience Advisor for GOAL. And she's been working on disaster, risk reduction, climate change adaptation, and resilience for over 20 years in Southeast Asia, Central America, the Caribbean, and East Africa. So thank you, ladies. I'm going to pass over to you now.
Thank you, Jacinta. I'll be sharing my slides. Good afternoon, everyone. I'll be presenting on fragility and health resilience, building health resilience of communities and health systems to climatic shocks and stresses. Fragility is a condition of vulnerability to a range of bad outcomes. Fragility Hold on. Okay. Fragility is always mentioned in line with fragile contexts and conflict contexts, And this is to describe settings that are usually exposed to frequent shocks and stresses, and a situation where local government capacity is very limited in terms of meeting the needs of the population. Fragile settings are divided into urban camp settlements, and these are typically overcrowded settings where there are limited infrastructure, basic infrastructure, and the epidemiological uniqueness of this area is communicable diseases are high, and there are other social determinants of health like unemployment and security and safety, access to healthcare and the like. And similarly, in rural and agrarian communities, even though they're widely spaced, there's no overcrowding problem, they are faced with lack of access to basic health services. And rural and agrarian communities are also lacking the availability of health workers, and beyond health, they are also exposed to frequent droughts and flooding and the like. Same with pastoralist communities. They are always mobile, and that makes it difficult for health services to reach them. But also the fact that they're always seeking to resources and resources such as water and pasture leads to more conflict and intercommunal problems. And same with coastal communities. They are typically depending on fishery and fishery-related economics, and overfishing is one of the challenges that we're seeing, and they are also withdrawn and remote compared to the basic health services, basic social services that are available to other communities. Health resilience. The Global Health Office of USAID defines health resilience as the ability of people, households, communities, systems, and countries to mitigate, adapt to, and recover from shocks and stresses in a manner that reduces acute and chronic vulnerabilities and facilitates equitable health outcomes. This is a very loaded definition. There are many, many components within it. And first of all, it helps us to think of health resilience in terms of the different levels that are individual, household, communities, and systems, and national level policy and overall engagement, and also global engagement. And the other key word here is to mitigate. And mitigation is alluding to preparation, anticipation, but at the same time response. And also the adapt to enables us to view that all interventions that are able to meet health resilience need to focus on small but reliable and sustainable approaches that can be adapted within the local social systems, and recover from shocks and stresses. So the shocks and stresses, I think these are the basis for us to even think about health resilience in the first place. We anticipate them, we try to predict them, we try to prepare for them. But when they come, we should be able to make sure that we're coping up at all levels, whether it's at individual, household, communities, or systems levels. And the other two important words here are vulnerabilities. Making sure that which are the vulnerable groups, how do we reach them, how do we improve their livelihood, their health, their capacity overall to overcome any shocks and stresses. And also equity is also very important, and making sure that the health system or any community involvement is reaching the most neglected and the most forgotten segments of the population. Climatic shocks result in the destruction of homes, health facilities and basic infrastructure. Climatic shocks also result in the interruption of health and social services and the reduction of food production. And even when food is produced, it results in very poor quality in terms of, because of poor quality of soil, poor quality of grains and crops, and it disrupts also food market systems and diversity of food consumed by individuals and households. And this is directly linked with food insecurity and also a major contributor of malnutrition in developing countries. As I said, health resilience is defined across the different levels within a country, but then we also come across with resilience capacities, and that's the way we categorize whether we have met the needs to make sure that we're enhancing resilience. The absorptive capacity, it's the ability to mitigate. It makes sure that exposure to shocks and stresses are understood, but also they are prepared for, and there are sufficient coping strategies to avoid the permanent loss or any difficult impact. And in adaptive capacity, again, it's focused on making sure that the coping strategy is also able to expand within a domain, and making sure that it is there and it is supported through the daily mitigation mechanisms, and making sure that that is made with supported system, which leads us to transformative capacity. And within transformative capacity, we're looking at the ability to recover, but not only just survive, but individuals, household, communities, and health systems are able to build back. And when they build back, they have incorporated all the system improvement that needed to happen, and the cycle continues with anticipating and preparing for the next shock. Isabelle?
Thank you, Mesrak. So this is the framework we use to analyze resilience and health resilience particularly, and also to design intervention to build resilience and health resilience. Here, the first question we need to ask when looking at resilience and health resilience is building resilience to what? So resilience to what? Here you can see, so on the left side, the shocks and stresses within the fragility context Mesrak was talking about. We need to have here first a very clear understanding of the risk landscape we are facing, or our target group is facing. So in the middle, the second question is clearly related, interrelated to the first one, is the resilience for whom? And that's our target group. And you can see it at the center, the round white circle. That's our target group. When we talk about health and in our in goal work, we focus mainly on women and children, and pregnant and lactating women and infant children under 5. So that would be our target group in the middle. And another third questions also related to resilience is, and also very linked to the other two, is the resilience of what? And here in health resilience, we will be looking at the health system. So, so yes, when we talk about resilience of what and the resilience of people, we will look at the system they depend on for their life and their well-being. So in this framework, we are focusing on the health system, that is a segment that you can see in green here. But you can also imagine that the whole cycle, and that there are other segments like the economic and market systems, the education systems, and the natural resource management systems, and so on, that are also very important for the overall resilience of our target population, and that we would need also to focus on. So here is the specific focus on health resilience and the health systems. And then on the right of the framework, you can see the resilience or the vulnerability pathways. That they would depend on the type of and the level of capacities that the people and the system have. And the pathways will either go one way, a very good way, the resilience one, and will deliver positive health outcome, or would go to the collapse pathways and we'll have very negative and bad health outcomes and well-being outcomes. So that's our resilience framework. Next slide, please. So when we, more concretely now, when we're talking about health system resilience and based on the framework you've just seen, one of the main points will be looking at and understanding and knowing the different shocks and stresses. And with that, what are the concrete things we will be doing in GOAL and other organizations working on health resilience is ensuring that we have in place very efficient early warning and response system for those things. In health, within the health sector, the disease surveillance is already sometimes quite well developed. But importantly now, with climate change and some climate-related events will have an increased impact on people's health and well-being, like floods, heat waves, heat stress linked to heat waves and hurricanes, and then the new vectors, and so leading to new diseases. So we will need to be able to develop much better linkages with the other type of early warning systems, those linked to climate events, with also within the health sector and not just surveillance of traditional diseases. So that's one of the concrete examples we need to work on when working on health resilience. And next slide, please. At community level, to work directly and to address directly the needs of our target population, so working at community level, a first tool that will help us identify the type of actions we need to put in place is a tool that we are developing right now, which is called the analysis of resilience, the analysis of the resilience of the community to disasters. There is a problem in the title here on health. So GOAL in 2014, I already developed a tool that is quite generic, looking at all aspects of resilience, but now we've developed a tool just for health and called RD Health. So it's a tool that we will be using at community level through a focus group discussion with community representative. And we will be scoring between 16 and 29 health resilience components that we will be discussing with the community, scoring them, and we will get an overall health resilience score. We will also get specific scores for the different type of capacities that Mesrak discussed: absorptive capacity, adaptive capacity, and transformative capacity. And this will be our entry point in working on health resilience at community level. So next slide, please. So that's to continue on working at community level on health resilience. So through the RD Health tool, we'll be able to locate most vulnerable groups within the community that we will have to engage very well with them. We will also be able to start identifying needs. I mean, the RD Health won't be enough to do to really go in depth with the different type of needs in terms of health resilience. So that's a very good entry point, but we will need to continue working on that at community level. Then social cohesion as well. We'll have to work on it. There is lots of evidence now that social cohesion is a very strong characteristic of community resilience for any type of shocks and stresses. So that's something that definitely we'll have to work on it. Of course, the RD will also help us as an entry point and as a trigger for developing community-led action plan for health resilience and preparedness, health preparedness and response. And finally, we will need also to work on bridging the gap between communities and health services and the health system at a wider level. And so that's what also Mesrak will continue talking about now.
Thank you, Isabelle. I'll be talking about strengthening health systems resilience. And health system resilience is the ability to maintain optimal system performance in times of crisis or adversity. However, achieving resilience requires constant balancing of alignment, collaboration, adaptation, and transformation of supply, demand, and contextual factors. So actual health service or actual health system is focusing on supply and demand pressures, but there is also the pressure that comes from context. And the context in fragile settings is characterized by shocks and stresses. And a resilient performance is a function of all these together. And health system, as we have a recent experience with COVID-19, is the first to be affected by any sort of a pandemic. Whenever there is an epidemic or a pandemic, the first system that is affected is the health system, because it is at the forefront of response to any health-related crisis. And in terms of climatic shocks also, the health system is affected. We now work in South, we have work in South Sudan, and we see that there are frequent flooding, or twice, sometimes more than twice in a year. There is flooding, and when there is flooding, health facilities are closed, and health facilities are temporarily relocated to another location, and people are moved to another location, and that results in significant disruption of services. And it's difficult to maintain optimal system performance in such circumstances. So there is the resilience for social systems, R4S. It was again developed by GOAL, and nowadays we're trying to adapt it to health system resilience. It was meant for market systems and livelihoods, but right now we are trying to use it for the health systems resilience. And this approach brings our focus and our attention to 6 important characteristics. One is connectivity, making sure that each part of the system is connected and they're communicating, and there is data sharing, there is sharing of resources, and there is actually a framework through which each subsystem is connected and working together. And the other is diversity, a diversity of services, making sure that health facilities and the overall district health system is able to provide various types of services. And apparently, health system that has a diverse services is able to withstand crisis than a system that is designed to provide few or one type of services. And the other is redundancy through use of private facilities to public services in terms of crisis, or using private workers to provide public services creates a redundancy, and the system was able to withstand any outcoming stress or shocks when there is when there is another avenue through which that can be, the deficit can be compensated. And very important is participation, making sure that all key actors in the system are represented and they are able to provide input to plan, execute, and monitor and evaluate every system response and system preparation to respond to any shocks. And again, this needs to be backed by learning, and it's really important to strengthen our information systems and align them with health management information system, and making sure that the local existing health information system is supported and integrated with any emergency response. And governance, again, is key. It enables district health managers, health facility managers, and policymakers to sit together and plan and execute an emergency preparedness and response, but also a building back better strategy that actually meets the need, and it is flexible enough to adapt to upcoming changes, but it also is poised to meet the demands of the population and aimed at improving health outcomes in an efficient manner. The USAID has developed its vision for health system strengthening. It's called USAID Vision for Health System Strengthening 2030. And we're very excited about this because it really brings out at the core quality, optimal quality of health services and equity, making sure that the system is inclusive enough to address the needs of the vulnerable population, and resource optimization for better health outcome, again, under enabling local organizations and cross-sectoral collaboration and learning, adaptation, and others. So this vision really lays out the support that the US government provides to health systems, but also it also supports the health systems, the outline of the health system that was defined by World Health Organization a long time ago. So we're now shying away from the WHO 6 blocks approach and trying to really see the health system from the overall social system and approaches. And that is actually the right way of looking at it. We keep on six building blocks, but they're not enough in their own. So, and when we come to health resilience, resilience needs to be locally driven. And that way we're able to bring sustainable changes. So we need to make sure that we engage local, informal, and formal sectors. If at all we learned anything from COVID-19, it is the importance of the engagement of local sectors, formal, informal sectors, community leaders, faith-based institutions, and enabling countries to harness local resources and not necessarily rely on external support for everything they do, and to develop local solutions to local problems. I welcome any questions you might have. Thank you for your attention.
Thank you, Mesrak, and thank you, Isabelle. That was great, and just a really nice introduction to, I suppose, bringing us right back to the very beginning in terms of what are we talking about when we talk about vulnerabilities, what are we talking about when we talk about health system strengthening and resilience, and what does that mean for people? And really interesting to bring us on that tour in terms of the tool that you now have and that you're starting to use, and how you're working as a team in terms of looking at addressing some of the issues that are highlighted with the focus groups that you've got. So it's really interesting, and I look forward to talking a little bit more in the general discussion time. So again, a reminder reminder to people, just use the chat box or questions and answers function if you want to start typing in questions. So hopefully we can get to some of those towards the end. So just to move on now, we're going to continue again with GOAL, and delighted to welcome your two colleagues, Hatty Barthorp and Mary Hallissey, both also in GOAL, and they're going to present on strengthening nutrition and health resilience for people vulnerable to the impact of climate change through a MAMI approach. So just to introduce the two ladies, Hatty Barthorp is the Global Nutrition Advisor for GOAL, and she is a Bachelor in Biomedical Sciences from Southampton University, and a Master's in Public Health from London School of Hygiene and Tropical Medicine. And she's been working in the field of humanitarian and development nutrition for over 18 years. Areas of interest include programming for excluded population, leveraging social behaviour change to improve the well-being of communities, and just trialling different ways of working to improve outcomes. And Mary Hallissey is joining her in this presentation, and she's the Global Health Advisor for GOAL and a public health specialist with over 25 years of experience in working in development and humanitarian health programs across a wide range of contexts. So Mary has experience in technical areas including health system strengthening, health resilience, social and behaviour change, and emergency health response. So thank you, ladies. I'll pass over to you.
Sorry, I just realised I was muted, having shared my screen, so I couldn't unmute myself. Let me just go back and share the screen again. There we go.
Great, thanks. And we can see that.
Lovely. I'll just get my slide. Brilliant. Thank you, Jacinta, very much. So I'm going to present the first part of this, and then Mary's going to take over. So as Jacinta said, we're going to be talking about strengthening nutrition and health resilience for people vulnerable to the impact of climate change. And I'm going to talk to you a little bit about the MAMI approach. But first, I just want to set the scene to illustrate how climate change is impacting food security. Then I'll give you a high-level overview of the MAMI approach, and then Mari will talk to you a little bit more about how it can be used to build health and nutrition resilience of communities vulnerable to the impacts of climate change. So climate change has significantly impacted food security around the globe, both directly through the consequences such as droughts, floods, erratic rains, pest infestations, etc., and also through secondary pathways where income affected by climate, and it might be through production like fishers and farmers, or perhaps through tourism, is linked to people's abilities to attain food and nutrition security. In the same vein, people's abilities to achieve food and nutrition security is also affected by their health. And the 2021 Lancet Countdown on Health and Climate Change, Code Red for a Healthy Future, the report clearly demonstrates an unabated rise in health impacts due to climate change. In fragile settings where socioeconomic and health systems are continually faced with shocks and stresses, women and children are disproportionately affected by shortages of food and lack of access to health services. One of the key outcomes of which is growth faltering in infants under 6 months. So if you look at this stat on the left-hand side, this is the data from an analysis of DHS data on infants from birth to 6 months across 54 countries, and it found that over 20% of infants were underweight. And whilst community management CMAM, which some of you might be familiar with, has revolutionized the treatment of children aged 6 to 59 months over the last 20 years, infants under 6 months are still neglected and overlooked. The longer-term ramifications of early malnutrition include mortality, increased morbidity. We've got medium-term issues around impaired development and educational attainment, and we also have long-term risks, which are associated with things like non-communicable diseases such as cardiovascular and metabolic illness. So what is MAMI? MAMI stands for the management of small and nutritionally at-risk infants under 6 months and their mothers. And the vision is that every small and nutritionally at-risk infant under 6 months and their mum is supported to survive and thrive. So the MAMI approach strives to achieve both these outcomes, the survival, but also the thriving, by acting as both a preventative and a curative service. So a lot of our services are purely focused on treatment, but this tries to couple both of them together. It does it by reducing the risk of adverse outcomes among infants under 6 months of age, but it also helps to rehabilitate infants already growth faltering by establishing good feeding and care practices within families. So the MAMI care pathway consists of potential risk identification through rapid screening, and that's followed by a more in-depth series of assessments covering infant health, growth, feeding, and maternal mental health and well-being to identify any underlying causes of risk. If there are those risk markers identified, then those in need will be enrolled into the MAMI programme, and tailored counselling to address any issues identified will be provided. It's a low-risk intervention. It's focused on counselling and support to address this widely neglected demographic of infants within the 1,000 days window of opportunity who fall between these 270 days and 450, so postpartum up until the 6-month bracket. So the MAMI care pathway was designed to basically build on existing systems and services. So it's not meant to be a parallel service. It's meant to fit in, nest within the existing health system that's there, and strengthen the links between those existing services. So in this, it's quite cluttered, but in this graphic, what we can see is the columns represent different time points from pre-pregnancy through to pregnancy, through to labour and birth, early postnatal, 6 weeks to 6 months, and then 6 to 59 months. And then the rows here looking at community level care, primary and secondary level care, and tertiary level care. MAMI has linkages with birth services at community level in this bottom circle to refer potentially small and nutritionally at-risk babies. It has links with the antenatal and birth services at primary, secondary and tertiary level health services, and also during the early postnatal period and up to 6 months, where case identification occurs, but also the subsequent management of these MAMI enrolled pairs, mother-infant pairs, actually occurs. It also bridges intervention services and perspective, because it includes a focus on nutritional care, clinical care, and social interventions. So MAMI is an approach that can be implemented to strengthen health resilience capacities at individual, household, and community levels. These resilience capacities are improved through stakeholder engagement, educating health workers and subsequently families on how to detect and seek MAMI services for their young infants, but critically through the provision of tailored counselling. So this enables mothers and families to care for the health and well-being of their children and themselves. So MAMI is of direct relevance to programmes across the nexus that includes fragile contexts affected by climate change. The approach has been tailored in a number of countries in different contexts, including Asia, the Middle East, and Africa. There's currently an RCT underway in Ethiopia. It's led by the London School of Hygiene and Tropical Medicine. It's in partnership with the Emergency Nutrition Network, Jimmy University, and GOAL as an operational partner. And it's focused on building stronger evidence towards future national scale up, because MAMI's only been piloted small scale at the moment. It hasn't been scaled in any one country yet. And MAMI has more recently been incorporated into part of the Momentum Integrated Health Resilience project that Mesrak mentioned, which is this 5-year USAID funded family planning, reproductive, maternal, newborn and child health project, which aims to build the health resilience of communities in fragile settings. So the MAMI approach provides a promising approach to build the health resilience of at-risk mother-infant dyads in fragile conflicts affected by climate-related shocks and stresses. And Mari is now going to talk a little bit more about this.
Thanks, Hatty. Yeah, and I just would like to link what Hatty has just presented there on MAMI back to Mesrak and Isabelle's presentation on health resilience and building capacities around building health resilience. So, so for these last few slides, I just want to make that connection and show how MAMI provides a promising approach to building health resilience of at-risk mothers and infants, particularly in fragile contexts affected by climatic shocks and stresses. And again, looking at this at different levels. So at individual and household level, where MAMI can help build resilience of mothers and infants and families by empowering them with the skills for self-care and positive health and nutrition behaviors. At community level, it helps to identify and manage, as we've said, the at-risk infants and mothers within communities, supporting them at community level and monitoring them at community level. And then at health system level, build the resilience capacities of the health system when MAMI capacity is integrated into the broader health and nutrition system. So Hatty, if you put on the next slide. Before I talk about those three levels, I just want to mention the MAMI MUAC tape. So this is, MAMI MUAC is essentially an extension or a variation on the family MUAC approach, which I'm sure you'll all be familiar with. So the use of these tapes to measure mid-upper arm circumference of children. And the second one down there is the conventional example there, where it's used to measure nutrition status of children aged 6 months to 5 years. So GOAL has now adapted this for use in children 0 to 5 months. You'll see the top level one there. So I think this it's just to highlight when we talk about building resilience that this is a very useful tool. And as we know, MUAC tapes are used both by health practitioners as well as mothers and families at community level as well to identify growth faltering. So next slide, please. Okay, so MAMI, as we said, can help strengthen health resilience at individual and household levels. So we can do this by building the capacity of mothers for self-care and positive health behaviors. And this will include things like exclusive breastfeeding, positive infant feeding practices, positive infant care practices, generally speaking. Mothers will gain skills around stress management, psychosocial support, family and paternal support, and as we said, early identification of growth faltering, and generally creates a strong sense of self-efficacy more generally at that level. Next slide. So at community level, MAMI provides, I suppose, a supportive environment for these at-risk mothers and infant pairs. So you'll have community healthcare workers that will be trained in MAMI, and they will be providing counselling and psychosocial support to mothers and families. It will facilitate case identification of these at-risk pairs and referrals of these for greater support, and in general, more positive health and nutrition and care-seeking behaviours more generally at community level. And finally, at health system level, if integrated into the broader health and nutrition service delivery, MAMI can help to build the resilience of the system to mitigate, as Mesrak has said, mitigating, adapting and recovering from shocks to that system. So this is because it can help ensure the health resilience of the vulnerable infants, less than 6 months, and their mothers. It can help in identification and management of low birth weight infants, preterm infants, etc., that we've mentioned, And also it helps identification and management of mothers who are struggling perhaps in terms of mental health issues or struggling with breastfeeding. It provides that, it will provide that general supportive environment. So if that's built into the system and you know, integrated into that broader health delivery system, then that will definitely build the resilience. And MAMI can also be integrated into the general preparedness and response capacity at national and district levels. So including surge capacity in response to a shock. Therefore, you know, the needs of at-risk infants under 6 months is factored into emergency preparedness efforts and early warning and response systems, like we have also mentioned already in terms of building resilience. So this is at all levels, this is how we feel that MAMI provides that promising approach and can help build resilience at those levels. So thank you.
Thanks, Mary, and thanks, Hattie. That was great, and it just led very nicely on from the previous presentation in terms of taking it to the next level, both of you know, thinking a little bit around how particularly climate change and focusing in on using a MAMI approach. And also then, Mary, just kind of, you give some really good practical examples of where health systems can be strengthened to have an impact in terms of climate, and thinking a little bit more practically about how interventions might be used. So that was great. Thanks a million for that, but I'm not going to delay too much. I'm going to move on to our next speaker, who is Clodagh McLaughlin, and thanks very much. Clodagh has stepped in to speak on behalf of Dr. Anne-Marie Meyer, who unfortunately wasn't able to be with us today. But I'm delighted that Clodagh is here, and Clodagh is a Senior Programme Officer with World Vision Ireland. She's a background in public health and global health, and a keen interest in health and nutrition programmes. So she manages World Vision Ireland's Irish Aid funded programme, AIM Health Plus. And she's going to talk to us today, Chloe's going to talk to us today about World Vision Ireland's adaptive programme for nutrition in the context of climate change. So thanks, Clodagh, for being with us today.
Thanks very much, Jacinta. Hopefully will work. Okay. Yeah, so thanks very much. I'm going to talk about our adaptive programming for nutrition in the context of climate change, with a focus on our AIM Health Plus programme. So AIM Health Plus is our Irish Aid funded PG2 grant. It's a maternal and child health programme in 4 countries, so Mauritania, Sierra Leone, Tanzania and Uganda. So the 4 countries were selected primarily based on their high levels of maternal, neonatal and under 5 mortality rates, and they're quite varied in terms of their climate change risks and socioeconomic conditions. The goal of the programme is to reduce neonatal and under 5 child mortality by 20% and maternal mortality by 15% by the end of programme in 2022. It was initially 2021, but there was an extension year granted due to COVID. And so it's got 5 key objectives. The first being that children and their mothers are well nourished. Children are protected from illness and managed appropriately when they're ill. Children and their caregivers access and utilize essential maternal and child health services. Health governance and partnerships are strengthened at the micro, meso and macro levels. And that maternal and child health outcomes are accelerated and amplified through the use of digital technology. So the programme uses the same broad approach across the different countries. So it's based on World Vision International's health strategy 711, employing 3 core project models. So these are TTC, which is a family inclusive behaviour change communication approach. targeting pregnant women and the caregivers of children under 2, largely through community health workers who visit households at times and targeted times throughout the first 2 years of the child's life. Then we have the COMS model, which is capacity building and empowerment model of health committees to coordinate activities, leading to increased community capacity, improved health policy and service environment. And they also work well in strengthening CHW programs. And then we also have CVA, which is a social accountability and local level advocacy approach that aims to address inadequate essential services like health services, or it could be education as well, by improving the relationship between communities and the government and empowering communities to hold the government to account. So the results for the nutritional indicators of the programme, such as wasting, stunting and underweight from the previous phase and also at midterm, we're suggesting that food security situation and causes outside the scope of the programme, such as climate change, were having a negative impact on reaching programme targets. And to address this, we did introduce some context-specific WASH and nutrition-sensitive interventions in each country, but we also considered it necessary to look further into the question of climate change and nutrition. So that's how this piece of work came about. It was conducted by Dr. Anne-Marie Mayer, an independent consultant, so earlier this year. And it looked at all the 4 AIM Health Plus countries. They were reviewed to assess the impact of climate change on the many potential causes of malnutrition, and also to map out the responses and adaptations that have been taking place to address these. So it consisted of a mixture of literature reviews, peer reviews, World Vision documents. Also interviews were conducted with World Vision staff, with local partners and community members, using a questionnaire designed around 3 key themes related to the underlying causes of malnutrition. And then there was also interviews and focus group discussions, which were conducted online or in person. So it was mainly done, I guess, virtually or online from a distance. So the findings of the piece of work concluded that, well, climate change can affect all types of malnutrition, undernutrition, over malnutrition, and the causes depend on the context and the relationship to climate change, which are wide-ranging and many beyond the scope of this. So the results from the study showed that climate change has exacerbated all the 3 underlying causes of malnutrition. So household food insecurity, inadequate maternal and childcare, unhealthy environment, inadequate health services, from UNICEF's model of the causes of malnutrition and death. 14 key themes across the 3 underlying causes were reported in most countries and related to climate change. So some examples of these would have been that agricultural production was severely affected by droughts and floods, women's time and work burdens had increased, food quality had deteriorated, food prices had increased, diets had deteriorated in quantity and quality, infant and young child feeding practices were affected by women's increased workload and a lack of food availability. Water shortages affected hygiene practices and agricultural production, and waterborne disease that had increased. So some problems are extremely difficult to address directly, such as the lack of water, droughts, storms of loss of livelihoods. But the approach taken by AIM Health Plus has been to do what is possible to improve the lives in these areas, I suppose. So because the model included its 3 core projects, it allowed for flexibility and enabling community responses and adaptations regarding nutrition sensitive interventions. So these largely focused on climate change adaptation, rather than mitigation. However, some approaches, I suppose, were a combination of the both adaptation and mitigation, such as conservation agriculture, that, for example, builds on soil organic matter and adapts, for example, building on drought resilience. And it can also improve nutrition across the 3 underlying causes. So some example adaptations in the program were the promotion of, as I mentioned, conservation agriculture and keyhole gardens, introduction of drought tolerant and biofortified crops, new water sources, gender equality activities, training on post-harvest handling, and measures to prevent communicable diseases. And the report found that the adaptations that were made by AIM Health Plus measured well against the global recommendations from FANZO and Tirado. So these are just, I've gone way too far, excuse me. So these are some of the recommendations from FANZO, I suppose, different categories of responses. So there's just 7 listed there along the left. So food supply chain impacts, food production, post-harvesting, storage and processing, and so on, with some examples of World Vision activities which fit into these categories of response. So AIM Health Plus implemented many activities in the 4 countries that follow the recommendations of FANZO, even without having like a comprehensive strategy to do so. Which is a sign that the program has adapted well to the context of climate change, and the countries are able to respond to the problems they and communities identify on an ongoing way. And this has been largely as well due to working with partners in each of the countries. It's been a key approach in addressing food security and nutrition, and the advantage to this would largely be that local partners are familiar with the context and can apply locally adapted services. So for example, in Tanzania, we had conservation agriculture and keyhole gardens, water harvesting, supported by a local partner. In Uganda, the project works alongside nutrition care groups to provide additional food and income for members. And then keyhole gardens and hygiene practices are also supported there. And in Mauritania, a local partner offers cooking demonstrations and are supported with community gardens as well as working closely with local agricultural extension workers in all cases. And some recommendations from the report are as follows. So I suppose the causes of climate change, they are global, and mitigation of these is much more beyond the scope of the project or this study. However, local measures can help communities to adapt. So given the far-reaching consequences of climate change on nutrition, well-integrated and flexible programs are required. These need to be comprehensive activities to cover all the underlying and basic causes of malnutrition. They necessarily span different sectors, such as agriculture, health, gender, disaster risk reduction, amongst others. Building resilience in each sector is essential, and gender empowerment is also key. A strategy for climate change and nutrition is needed, which draws on a set of core project models and a mechanism to diagnose and adapt according to the context. Flexibility, and for this, flexibility can be achieved in several ways. Working with local partners increases context-specific flexibility and can draw on Indigenous knowledge. And the third recommendation is capacity building at all levels of the organization for climate change adaptation. So drawing up guidelines, using in-house and global resources is necessary, with a full list of possible measures to take, for example, how to make agriculture more climate resilient and how to respond to health challenges, or how to introduce surveillance, and having an algorithm to help programs respond in a timely way would be helpful. The fourth recommendation was that strong community resilience is essential to adapt to climate change, and this can be nurtured to help communities cooperate, adapt, advocate and innovate in the face of the challenges. With problem-solving skills can be learned so communities and local partners are confident in making suggestions and innovating. An example of this would be participatory action learning. And the final recommendation was that a systematic monitoring system designed around the 3 underlying causes of malnutrition and sub-themes are necessary for organizations to share their experiences, build evidence about challenges and effective strategies. And this should include quantitative and qualitative data and local perspectives. So they were just some of the key recommendations from the report that Anne-Marie put together for us. And so that is all my presentation. So thank you very much, and I'll take any questions at the end. Thanks.
Perfect, Claudia. Thanks a million. And that was a great presentation, just to kind of round them up and finish off the presentations part of this session. And it led very nicely on a lot of messages consistent with what the previous speakers had mentioned around the importance of kind of being local, involving the local community, and also just the detrimental effects of climate change on the communities. Now, I know we're running a little bit behind time in terms of where we hope to be at. I'll have more time for a discussion, but I'm going to open the floor if anybody particularly has any questions. I know I have a few, but I do want to include everybody. If anybody has a particularly burning question, I'd just say you try and keep your question as brief as possible. And if you want to unmute yourself, and maybe if you can highlight your or show, activate your video as well. Any questions? No, okay, there's none coming in so far. So can I ask a general question and throw it open to all of the panelists? And thanks very much. I loved all of your presentations, and it was each one of you brought something new to the table. But can I ask a general question around, like, where do you think, or how do you think we can play a role in terms of integrating? So we talked a good few years ago about, and it still is very much there in the background, about kind of nutrition sensitive projects, but the same kind of thing in terms of, you know, thinking about climate change and having projects where that climate and the impacts of climate are transversed across all different types of programs and systems, and how that can be done, and like what role do the NGOs, what role can they play in that, or what kind of research should we be looking at to ensure that we get the data to actually do that? I'm not sure that open to all speakers, or if somebody wants to take that one. Will I direct it to somebody?
Jacinta, I'll start, but I'm probably the least qualified to answer. But I just think it's interesting. We were developing some new research with our partners in Malawi, our current partners in the University of Health Sciences, but also the Malawi University of Science and Technology. And they were very keen, and you could say insistent on looking at the energy, you know, renewable energy, sustainable energy, the whole kind of system. In that case, it was about solar power, which is a new area for me, but it was about supporting, you know, community, rural maternity care, linking in with the electronic engineers in Malawi, and it happened to be in Dublin City University as well. And that was, you know, we were responding to a particular call for science and technology projects, but it was led by the need for, you know, rurally based midwives who won't have, you know, reliable electricity, and just how could we all kind of work together. And, you know, it seemed to kind of
there was no tension between any of that. It was all in the same direction, you know, would improve access to care and would meet, you know, national agenda for only, you know, having new initiatives, having renewable energy sources. So I think it's just, you can just see it kind of shifting across all our consciousness.
Yeah, no, it's really important. And even in terms of, I mean, we always talk and say about the challenges of working within our silos. And this is an area, particularly if we think about kind of new technologies or that might be coming on board in terms of how we might need to embrace other professions, and engineers, or, you know, is a good example. In terms of how we can work together a little bit closer in terms of, you know, we all have the common goal, and that can be the climate agenda. Does anybody else want to come in with questions? No?
Jacinta, maybe just on that point, yeah, I mean, tackling climate change, you know, an approach that cuts across is quite a big question. But maybe just to give an example of maybe some work we've been doing around, you know, making that link between climate change and population growth, and working with youth around sexual reproductive health programming, that, you know, makes that link between the environment that young people live in and, you know, sexual and reproductive health issues. And we did work on that in Malawi a couple of years ago around working with youth around climate change and I suppose creating awareness on issues around climate change more generally, and activities around climate sensitive agriculture, etc. But also making that link with sexual reproductive health, population growth, you know, looking at, you know, given the demographic bulge and, you know, the large youth population, and you know, it gives, it links well, I think, in that respect, and that had been quite, just one example perhaps. But
thanks, Marianne. It's a nice example, and it does show it does show how broad it can be. I'm conscious of time, but there is one question that Frida Gannon has just put in the chat box there, and I might just read it out, and I'm not sure who might like to take this, maybe Marshad or Isabelle. How can the proposed interventions be applied in challenging, fragile, conflicted states where we're increasingly substituting for non-functional Ministry of Health Services deliveries? And she's given examples of Kordofan, Sudan, Amara, Ethiopia now. Yes, Mesrak, you have your hand raised.
Yeah, that's the call I've just come off now with concern Sudan and Ethiopia teams. We don't have access to a lot of our ECO-ERNI funded facilities we're supposed to be supporting, and I don't see it being resolved before the end of year, if we're lucky.
Thank you. Thank you for this timely question. Actually, I'd like to take a step back in answering this question, because we need to really understand that even though we work on health interventions, we should not be expecting everything from the local Ministry of Health. So that's why I was bringing everyone's attention towards looking at other sectors, cross-sectoral collaboration, but also the private sector and also the informal sectors. And before any of the programs arrive, these communities are surviving, and we really need to understand how they're doing it and who are in charge. And in addition, I also see that this silo approach in many programs is that there is no involvement of local other institutions. For example, higher education institutions, they have a very expansive program in providing outreach programs, health services to the community. And then we need to also approach faith-based organizations, and who are they, and what are the services, the package that they provide. And because before the formal health sector is in connection with the community exhausts other avenues. And mostly the health facility is the last resort for communities in societies. And specifically to the Amhara in Ethiopia, which I'm very familiar about, is that the current situation is that health facilities have been damaged because of the insurgence of TPLF. So we're the challenge right now is different from maybe a few months ago, because right now is the conflict has expanded, and every time the TPLF militia passes out, what they do is they damage health facilities, they damage public institutions. It's as if they're really angry at people in general. So that is a different situation. But in under circumstances of other fragile settings, particularly in climate settings, is that we need to really think outside the box, and the traditional approaches are not going to work unless they are backed by the different sectors, higher education institutions, faith-based organizations, and most importantly, the private sector. Thank you.
Thank you, Mesrak. I think unfortunately we're just at time, and I would like to continue the conversation. And I suppose in some ways this is just really the beginning of it, and hopefully we'll continue on throughout the year. Because I don't want to keep people from the next part of the conference. So just to say thank you all. Thank you to all our speakers. So we had Anne Matthews, we had Mesrak Nadew, we had Isabelle Bremaud, we had Hatty Barthorp, we had Mary Hallissey, and we had Clodagh McLaughlin. And thank you all so much for your time, and thank you all for joining in. And I'm going to sign off with just to say, save the date for the 22nd of November. We hope to run a webinar looking, or a Zoom looking at new forms of organising food and nutritional security for children in crisis in India and in the UK. And that's our website there, and do get in touch and let us know how we can better support you. And thanks. I'm just reading a few messages there in case we missed anything. So no, thanks a million. Hattie, you were just agreeing there, communities. Okay, I'm conscious. Anybody want to say any final words before we sign off? No? Okay, great. Thanks very much, everybody, and enjoy the rest of the conference, and be in touch. Okay, take care.
Thanks,
Bye.
Jacinta.
Thank you.
Thanks, everyone. Bye. Bye.
Thanks. Bye. Bye. Bye.